Okay. This patient has signs and symptoms of phencyclidine intoxication. In phencyclidine intoxication, there is disorientation and severe agitation, aggression with delusion of enhanced strength, psychosis, tachycardia, hyperthermia, and nystagmus and ataxia. PCP is a dissociative drug of abuse that has anesthetic and analgesic property. It acts on NMDA receptor, excitatory and psychotic effects, dopamine, norepinephrine, and serotonin receptor, adrenergic and dopaminergic effect, and the sigma receptor complex, psychotic and anticholinergic effect. In many cases, PCP use can lead to psychotic and violent behavior, diminished pain perception, and subsequent physical injuries. The onset of pain, the onset of action is rapid, and the duration of the action is generally less than 8 hours. High dose cases, high dose cause severe hypertension, seizure, rigidity, and life-threatening hyperthermia. PCP intoxication is treated with PCP intoxication is treated with both suppurative therapy and benzodiazepine. Okay, do you want me to read? Okay, option C. Methamphetamine intoxication can cause severe psychomotor agitation, hallucination, tachycardia, hypertension, but nystagmus is less common. Methamphetamine intoxication may last up to 20 hours longer than PCP intoxication. Yes. Okay. This patient preference for solitary play, repetitive stereotypical movements, hand biting, and fixated interest in cars are suggestive of autism spectrum disorder. ASD is 4 times more common in male individuals, and symptoms become apparent in early childhood. By age 4, children should engage with others in imaginative as well as reciprocal play using variety of toy rather than the solitary and repetitive play with intense fixated interest, playing with cars for long period, lining up cars seen in this patient when children are diverted from their preferred activity or when their routine is changed, it can result in distress and present as temper tantrum. Stereotypical or repetitive movements such as head banging, head biting are often used to self-soothe in patients with ASD. Language impairment in ASD, only using a single word at age 4, and is variable and can range from subtle abnormalities of pitch and odd word choice to absence of functional speech. Okay, it's not disruptive. Option C, it disruptive mood dysregulation disorder, recurrent developmentally inappropriate temper tantrum occur. Diagnosis should not be made prior to age 6, and the outburst should not be better explained by another disorder such as ASD, DMDD, disruptive mood dysregulation disorder would not explain a preference for solitary play and restricted interest. Okay, it's not intellectual disability. ASD may present with speech delay as well as intellectual disability. Isolated intellectual disability ID, however, would not explain a lack of responsiveness. Children with intellectual disability still try to communicate non-verbally when necessary and engage in play with others. Diagnosis of intellectual disability requires standardization test and is not given to patients age less than 5. And it's not option E, Lesch-Nyhan syndrome. Although this patient engages in hand biting, he does not display other characteristics feature typical of Lesch-Nyhan syndrome, including motor dysfunction, dystonia, spasticity, breathing movements, nephrolithiasis, or gout. Got it? Okay, this patient has characteristic symptoms hoarding disorder, a new disorder in DSM-5 that is distinct from obsessive compulsive disorder. Hoarding disorder is characterized by accumulation of large number of possessions that may clutter um, living areas to the point that may unusable. Patients experience intense distress when attempting to discard possessions regardless of their actual value. Social isolation due to embarrassment, being um, being unable to being unable to invite people to their home may also occur. Extreme cases may be associated with unsanitary conditions and fire risk due to block exit. CBT, and especially targeted to hoarding behavior, is the most effective treatment. Specific technique include education, motivation, interviewing, skill training in organization, decision making, cognitive restructuring, dysfunctional thoughts, and gradual exposure to discarding possessions. Although SSRI SSRI are often tried based on their efficacy in treating obsessive compulsive disorder, their efficacy is treating in hoarding disorder without obsessive compulsive disorder is limited. SSRI can be considered as an adjunct to CBT and can be helpful in treating comorbid depression and anxiety disorder. Got it? Maybe. Tetrabenazine is the drug for Tourette syndrome T for T, and methylphenidate for ADHD. Okay, this patient has this patient condition difficulty associated with chronic worry, tension, and restlessness are suggestive of generalized anxiety disorder, a common anxiety disorder of the childhood and adolescent. Worrying may frequently cause excessive worrying may frequently cause chronic impair excessive worrying may frequently cause cognitive impairment, including feeling in the mind is going blank, easy distractibility, indecisiveness, catastrophic fear of the worst case scenario, muscle tension, and physical restlessness, fidgeting, leg shaking are characteristic features. Adolescents with GAD are often perfectionistic and worry excessively about academic performance. When GAD symptoms are severe and impair social and academic functioning, pharmacotherapy is appropriate and is treated. Pharmacotherapy is appropriate and typically combined with CBT and SSRI are considered. SSRI are considered. Okay, when GAT syndrome are severe and impair social and academic functioning, pharmacotherapy is appropriate and is typically combined with CBT. Selective serotonin reuptake inhibitors, sertraline, are considered as the first-line pharmacotherapy for GAT in children and adolescents. Okay, why not hydroxyzine? Although sedating antihistamine, hydroxyzine can be used to treat short-term situational anxiety like preoperative anxiety. It is considered first-line treatment for pediatric GAD. And the beta blocker propranolol is for the performance anxiety in children. Next.
That is blood pressure is high, physical system mild elevation,
Okay. All patients should be screened for unhealthy alcohol use, and those identified should receive a brief counseling intervention geared the patient's level of awareness of the problem and the degree of motivation to change. This patient has been drinking excessively more than 4 drinks per day and is concerned. Uh, uh, this patient has been drinking excessively more than 4 drinks per day is considered problematic in men with evidence of liver toxicity, worsening hypertension, and possible negative consequence of his marriage and family. In counseling in counseling this patient, the physician should take into account the physician should take into account that the patient does not recognize his the patient does not recognize his drinking as problematic and is therefore probably not going to consider changing his behavior. Like stage of pre-contemplation. However, the patient does not acknowledge. However, the patient does acknowledge that he would have liked to attend his daughter's basketball game. Having him connect to his alcohol use to negative effect on next day functioning may increase motivation to change motivational intervention. Once this patient is able to recognize that this use is this use is causing problem, he will likely be more receptive to a trial of decreasing or abstinence or abstaining from alcohol. Okay. Yes. No, no, no. Yes. It's I am now looking. See, he is recently diagnosed with hypertension and his blood pressure is 180. So it is pheochromocyte. When I say that may not pheochromocytoma, I look at the pressure. So he was diagnosed with hypertension. I am extremely sorry. Okay. So this patient's episodic headache, diaphoresis, tachycardia, palpitation, and anxiety symptoms in the setting of new onset drug resistance hypertension, new onset drug resistant hypertension, hyperglycemia with a normal BMI are consistent with a diagnosis of pheochromocytoma. Signs and symptoms of pheochromocytoma are caused by catecholamine excess. However, 50% of patients with pheochromocytoma are symptomatic, and even in symptomatic individual, the diagnosis is frequently missed due to intermittent nature of symptoms. A pheochromocytoma is commonly diagnosed at age 30 to 50 and is associated with autosomal dominant disorder of the von Hippel-Lindau syndrome, multiple endocrine neoplasia type 2, neurofibromatosis. Measurements. Okay. Okay. Pheochromocytoma is most commonly diagnosed at age 30 to 50 and is associated with autosomal dominant disorder of the von Hippel-Lindau syndrome, multiple endocrine neoplasia type 2, type 2 neurofibromatosis type 1. Measurements of urinary or plasma fractionized metanephrine and catecholamine are used to make the diagnosis. Physicians may have a high index of suspicion for pheochromocytoma, as it may be misdiagnosed as psychiatric disorder in otherwise asymptomatic patients. Okay, next. Do you want me to? Okay. Do you want me to read the other explanations too? Okay. Okay. This is gender dysphoria, and these patients discomfort with the incongruence between gender identity and birth assigned gender is suggestive of a gender dysphoria. Patients with a gender dysphoria typically describe not identifying with the assigned gender since childhood or adolescence and are distressed by the development of unwanted secondary sexual characteristics that do not reflect their gender identity. They have a strong and persistent desire to live and be treated according to their experienced gender. Gender dysphoria should be differentiated from the gender non-conformity, in which individuals do not conform to stereotypical gender roles but still identify with their assigned gender. Okay, although cultural attitudes to gender diversity are changing, patients may encounter bullying and discrimination of the gender dysphoria in adults is associated with an elevated prevalence of psychiatric comorbidities, especially mood disorders, anxiety disorders, suicidality. Gender identity affirming care can include psychosocial support, hormonal therapy, gender affirming surgeries. Okay, it's not body dysmorphic disorder, which is one of the important differential diagnoses. Okay, GD and BDD are both characterized by a strong desire to change physical features that are distressing. However, these patients' breasts are distressing because they signify assigned gender and are incongruent with experienced gender. Body dysmorphic disorder should not be diagnosed in patients who are preoccupied with changing only their primary and secondary sexual characteristics and who met the other criteria of for gender dysphoria. I don't get that. Yes, yes, okay, that is gender conformity, non-conformity. Okay, okay. This is specific phobia. This patient's fear of heights is consistent with the diagnosis of a specific phobia in which fears of specific objects or situation phobic stimulus. The patient's treatment for specific phobia is cognitive behavioral therapy, which involves exposure to the phobic stimulus in a controlled setting. Exposure is typically performed in a gradual manner. Systematic desensitization, uh, systematic desensitization, which results in decreased anxiety over time, through habituation or extinction. Although in vivo exposure is optimal, imaginal and virtual reality exposure are also effective and maybe more feasible. Exposure therapy have been shown to be superior to pharmacological treatment in specific phobia. Yes. the selective the selective serotonin reuptake inhibitor sertraline are first line treatment for panic disorder, generalized anxiety disorder, not specific phobia. The patient does not have the spontaneous unprovoked panic attacks required for the diagnosis of the panic disorder. His anxiety is specific to the repercussions of his phobia, phobia on his work performance and is not characteristics due to diffuse anxiety seen in generalized anxiety disorder. And the last, trauma focused psychotherapy is a form of CBT used to treat PTSD. This patient this patient does not describe intrusive symptoms, flashback, nightmare, pervasive hyperarousal, and negative thoughts related to his cousin's fall, which would be expected in PTSD. His recent onset of anxiety in response to phobic stimulus of riding the elevator is characteristics of specific phobia. Okay. Okay, it's bulimia nervosa. These patients' preoccupation with the body shape, recurrent eating, recurrent eating binges, followed by excessive exercise, are suggestive of bulimia nervosa. So these patients' preoccupation with body shape and recurrent eating binges, followed by fasting and excessive exercise, are suggestive of bulimia nervosa. Loss of control during binges, followed by feelings of disgust, guilt, depression is common. Although patients with bulimia nervosa often engage in self-induced vomiting, these symptoms is not necessary for diagnosis. Other compensatory behavior, fasting, excessive exercise, as in this patient, misuse of laxative, enema, diuretics, diet pills, Binges and inappropriate compensatory behavior may occur at least once a week for 3 months for the diagnosis. In contrast to individuals with anorexia nervosa, patients with bulimia nervosa are normal weight to overweight. Signs of bulimia nervosa include hypotension, tachycardia, dry skin, menstrual abnormality, electrolyte imbalance, hypokalemia, hypochloremia, metabolic alkalosis. There may be erosion of dental enamel, parotid gland hypertrophy, can be seen in patients who vomit regularly. Treatment consists of nutritional rehabilitation, cognitive behavioral therapy, and pharmacotherapy with fluoxetine. Got it?
Yeah. Next,
Okay.
can you tell me when this is important in
He does not has like OSA. It's well, he is not snoring no, occasionally, but he there is no shortness of breath, which is one of the feature of the OSA. Maybe and his BMI is very high, but no, yes, BMI is not that high. Okay, maybe I don't know. I don't think so. It's OSA. Okay, decreased REM sleep latency. So this patient's 3 week history of low energy, 3 week uh, 3 week history of low energy, sleep disturbance, decreased interest, impaired concentration, as well as all the features I have. Okay, this patient's low energy, sleep disturbance, decreased interest, and impaired concentration, as well as finding of psychomotor slowing on mental status examination is consistent with MDD. Sleep abnormalities are a core symptoms of depression. Sleep abnormalities are a core symptom of depression. May include difficulty falling asleep, interrupted sleep, sleep interrupted sleep, early morning awaking, and hypersomnia. A characteristic polysomnographic finding in MDD is decreased REM sleep latency. Decreased REM sleep latency in the time from sleep onset until the start of the first REM sleep period, which is considered a biomarker for depression. Other sleep findings in depressed patients include decreased slow wave sleep and is decreased slow wave sleep and and increased REM sleep duration and density, as well as disruption in sleep continuity. Sleep disturbance in MDD typically return to normal with antidepressant treatment. So sleep disturbance in MDD typically return to normal with antidepressant treatment. Okay. Increase Option B, increase periodic limb movement during sleep, like involuntary jerking movement of the leg may cause nighttime arousal, which typically lead to excessive daytime sleepiness. Periodic limb movement disorder would not explain this patient's marked depressive symptoms. Choice C, slow wave sleep, also known as deep sleep, is decreased. Slow wave sleep, also known as deep sleep, is decreased and not increased in MDD. And choice D, loss of normal REM sleep atonia is a feature of REM sleep behavior disorder, a parasomnia characterized by dream enactment behavior. And choice E, sleep related hypoventilation and apnea on polysomnography are characteristics of obstructive sleep apnea. These patients commonly have observed breathing pauses, snoring, and gasping for air, as well as excessive daytime sleeping rather than early morning awakening. Although this patient has some risk factor for OSA, male, hypertension, snoring, he has a normal BMI and no evidence of interrupted breathing. MDD is better explanation for his 3-week history of symptoms. Got it? Okay. In 2007, the US FDA extended its warning that all patients less than 25 should be informed. All patients age less than 25 should be informed about the small risk of becoming suicidal during antidepressive antidepressant treatment. The warning was based on studies showing a slightly increased risk of suicidal thoughts and behavior among a small group of child and adolescent patients treated with antidepressant compared to placebo. Decision regarding prescribing antidepressant for adolescent must weigh the risk of antidepressant related to suicidal thoughts and behaviors against established benefit of antidepressant and the long-term risk of completed suicide in untreated depression. Although there is although there is ongoing debate Although there is ongoing debate about the evidence for a link between antidepressants and suicidality, the consensus among experts in practice guidelines is that the benefits of antidepressant for moderate to severe depression outweighs the risk. Antidepressant treatment should not be withheld due to concern or limited to patients who have failed psychotherapy. Next, probably because all the drugs regarding ADHD, modafinil was for ADHD too. Okay, non-opioid like non-sedative drugs like atomoxetine. We have read a box like amphetamine and methylphenidate. These two drugs are for these two drugs has some sort of sedating sedating property, so not sedating like addictive property, but atomoxetine does not have this addictive property, and other drug like clonidine, these are the second line, that's why it is not used here. Okay. Yes, stimulants and non-stimulants is like atomoxetine and alpha 2 adrenergic and clonidine. Yes. Sorry.
Mechanism of holiday, like
It's agonist drug bind with the receptor and produce pharmacological effect.
but does it include
I don't remember actually, so I can't say you. It's your wish. We can skip. Okay.
So he
Dextromethorphan is a cough syrup like antitussive. It's a sedative opioid like sedative. It's, look, he has some sort of infection. Respiratory. Then serotonin syndrome. There may be hypertension. Is it alcohol? He is not admitted in the hospital, isn't? Oh no, no. Anticholinergic, dry mouth, blurred vision. Either B or D. Answer B or D. No. D. Physostigmine is for yes. Physostigmine for anticholinergic toxicity, like, but may not be. Okay, you give your answer. You are in the right track. You said the serotonin syndrome. That's why I said you are in the right track. But I was sure that it is in between B or D. It's not the five stigma one.
is taking more. Okay. Okay, yeah, that's why I made it.
Five stigma. In OPC poisoning, what are the drugs we give? Organophosphorus compound OPC poisoning. Yes, yes. That in that case we give actually I as far I remember physostigmine, atropine and pralidoxin. Sorry, atropine, pralidoxin. So where? Okay, okay. Serotonin syndrome. Okay, start with the box first. Serotonin syndrome causes serotonergic medication, especially in combination with SSRI, TC, and tramadol, and drug interaction, serotonergic medication, and MAO inhibitor or linezolid, and intentional overdose of serotonergic medications, and serotonergic substance MDMA, serotonergic substance like MDMA, dextromethorphan, and amphetamine. These are the uh, serotonergic substance. Clinical feature: mental status changes, anxiety, agitation, delirium, autonomic dysregulation. There is diaphoresis, hypertension, tachycardia, hyperthermia, vomiting, diarrhea, neuromuscular activity, tremor, myoclonus, hyperreflexia. Management is discontinuation of all serotonergic medication, supportive care, sedation with benzodiazepine, benzodiazepine, and serotonergic antagonists like cyproheptadine. Cyproheptadine if supportive measures fail. Cyproheptadine if supportive measures fail, and immediate sedation, paralysis, and tracheal intubation if temperature is more than 41. Okay, this patient taking SSRI. Uh, this patient Taking SSRI has altered mental status, autonomic instability, hyperthermia, hypertension, tachycardia, mydriasis, and neuromuscular excitability, hyperreflexia, ankle clonus, a triad concerning serotonergic symptom. Although it typically follows increased SSRI, although it typically follows an doses, increased SSRI doses, a serotonergic syndrome can also be precipitated by concomitant use of serotonergic agent. This patient recently began taking antitussive dexamethasone, which primarily activates the sigma opioid receptor to inhibit cough, but also has serotonergic activity at the level of 5-hydroxytryptophan receptor. Management is all serotonergic medication, discontinuation of all serotonergic medication, the use of management of severe hypertension and short-acting antihypertensive, management of severe hypertension with short-acting antihypertensive esmolol, and IV hydration, evaporate and connect and con- convective cooling, fanning, water mist. Antibiotics are not used because hyperthermia is due to sustained muscle contraction, not elevation in the hypothalamic set point. And benzodiazepine to improve agitation, decrease muscle tension, which reduces hyperthermia and decreases blood pressure and heart rate. In patients who are unresponsive to benzodiazepine or supportive, ciproheptadine are used to lower serotonergic activity through antagonism of 5-HT1A and 5-HT2A receptor. Serotonergic syndrome can have a relatively rapid onset and progression. Some patients require intubation and sedation. Severe hypothermia. Got it? What are the features you have find in here, like generalized anxiety? Okay. So this patient, this patient 6 month history of excessive worry and anxiety, restless, irritability, difficulty concentrating, muscle tension, sleep disturbance is consistent with generalized anxiety disorder. In generalized anxiety disorder is a chronic treatment of generalized anxiety disorder includes cognitive behavioral therapy, medication, and combination of both. Preferred initial medication for GAD is SSRIs or SNRIs such as venlafaxine. No antidepressant has shown to superior no antidepressant has shown to be superior treatment, so medication selection is based on adverse effect profile and the patient's history. SSRI or SNRI are effective in treating depression, a common comorbidity. Benzodiazepine, diazepam, lorazepam are effective. Benzodiazepine like diazepam, lorazepam are effective but considered as a second line treatment due to risk for misuse, dependence, and tolerance, and the potential for withdrawal syndrome. The rebound effect with abrupt discontinuation. Benzodiazepine can be used when antidepressants are effective, poorly tolerated, but should be avoided in patients with a history of substance use or significant comorbid depression. They can also be used as an adjunct to manage acute anxiety, uh, acute anxiety while waiting for SSRI or SNRI to take effect. Buspirone, buspirone is a non-benzodiazepine anxiolytic has been shown has been used to treat generalized anxiety disorder in patients without comorbid depression or panic symptoms. Although it has lowered the onset of action and weaker anxiolytic effects than benzodiazepine, it can be helpful in patients with high risk benzodiazepine misuse. Got it? Okay.
Women go to the ED by her husband for what and we can classify as simplified, the most of the cases don't the patients receive.
Okay. Although this woman has a diagnosis of schizophrenia, it is well controlled and there is no indication that her decision making ability is impaired due to psychosis or other features. She is conscious and is able to participate in her own care and can give consent for the procedure. Capacity is capacity is a patient's ability to understand the illness and treatment options and consequence to express a choice reflecting the preference. It is used in medical conditions to determine if someone has the ability to give informed consent to receive or refuse a specific intervention. Assessing capacity is especially important when someone's cognition may be impaired, such as neurological conditions, dementia, or severe psychiatric illness. Having the presence of psychiatric diagnosis and does not render a patient incapable of making decision. Got it?
Yes.
Yes, next.
So in my opinion, the difference is taken into account. She has a different experience versus the last
He has some like narcissistic quality also. And what is the borderline personality disorder?
the
What?
the one after dementia and
Okay. Okay. So he has not that borderline. He is on relationship and he is just possessive personality. Like he's sorry.
so
Yes. At the time of fight. I don't know why it is antisocial. I thought because the last words is related to narcissistic one. Okay. This patient's reckless disregard for safety. This patient's reckless disregard for safety of self and others, unstable employment history, and lack of remorse are suggestive of antisocial personality disorder. Antisocial personality disorder is a lifelong disorder characterized by a pervasive pattern of disregard for and violation of the rights of others, beginning in the childhood or early adolescence and continuing into adulthood age more than 18. Regard for diagnosis as essential feature for diagnosis of the antisocial personality disorder is evidence of conduct disorder prior to age 15. So for antisocial personality disorder, there may be a presence of conduct disorder, and the conduct disorder should be more than should be present before 15, and after eating 18 it is called antisocial personality disorder. Individuals with antisocial personality disorder tend to physically aggressive, impulsive, and may repeatedly get into fight. Additional typical behaviors include illegal activities, illegal drug use, theft, lying and manipulation of others for personal gain. These patients' arrogant self-appraisal and lack of remorse and failure to accept responsibility for his own behavior. Blaming teachers for not getting into college are characteristics of antisocial personality disorder. Disorder. Okay, it's not option E and F. Individuals with narcissistic personality disorder often have exaggerated sense of self-importance and lack of empathy, but are impulsive, do not typically engage in violent or illegal activities. In paranoid personality disorder, behavior is motivated by distrust and suspicious rather than a desire for personal gain or to exploit others. Okay, these patients believe that a new caster, these patients believe that a newscaster is in love with her, combined with the absence of prominent psychotic symptoms or significant mood disturbance is most consistent with delusional disorder. Erotomanic subtype. Delusions are false beliefs that are firmly held despite conflicting evidence. Delusional disorder is a subtype based on the delusional theme erotomanic, grandiose, jealousy, persecutory, somatic. In the erotomanic type, efforts to efforts to contact the subject of the delusion are common and may result in legal difficulties. In comparison with patients with schizophrenia, including delusional disorder, lack of their prominent psychotic symptoms, they do not have prominent hallucination or grossly disorganized behavior, typically have higher functioning, and their behavior unrelated to their delusional concern, often normal. Okay, yes,
Before the movie is going to begin, we have to definitely that's immortalized. What is going to immortalize it?
okay. So these patients are recurrent suicidal behavior, mood instability, unstable relationships, inappropriate anger, impulsivity, abandonment fear, and stress related paranoia. And these dissociations are associated with borderline personality disorder. In addition to suicidal thought, gestures, and attempts, these patients often engage in non-suicidal self-injury, cutting, and burning. A history of childhood trauma, a history of mm, a history of childhood trauma, physical and sexual abuse, neglect, common in patients with borderline personality disorder. Insecure attachment to the caregiver may underlie the stable relationship and fears of abandonment commonly seen in this disorder. Dissociative symptoms of this patient enjoys. Okay. Dissociative symptoms are common in those who have been traumatized. Got it?
Can you repeat this one?
Yes. Yes. The mood disturbance in BPD. The mood disturbance in BPD characterized by marked mood reactivity, moment to moment fluctuation, often triggered by psychosocial stressor, loss of mood reactivity in patients with severe melancholic depression. The mood does not improve with improved circumstances.
Okay, so we have now
Yes, it is stress. Pro
think so.
acute stress disorder. What's the timeline? It's between,
It less than a month.
yes. It's not normal grief.
It's not like that.
Oh, I think so.
It lasts like 40 days after.
You are right. Okay. This patient's acute. This patient's acute onset disorganized bizarre behavior, keeping lights off, closing eyes, covering ears, disorganized speech, nonsensical responses, and probable hallucination, whispering to himself in the dark following the traumatic death of the father. Okay, following traumatic death of his father is consistent with brief psychotic disorder. Brief psychotic disorder is a psychotic symptoms lasting between 1 day to 1 month. So it is like acute stress disorder. So 1 day to 1 month. As in these cases, it is often triggered by stressful event and can be specified as marked stressor. When triggered by the loss of the loved one, BPD should be BPD should be differentiated from a normal grief reaction. In a normal grief reaction, individuals may have hallucinations, experience that experience that are centered on maintaining connection with the deceased. Their behavior, speech, however, are not disorganized and they are still able to relate to others. In contrast, this man's behavior is bizarre and his response on examination is nonsensical. Okay, car. Okay, yes. মানে patient should be in the scenario. Yes, this is important. Initially, I thought MDD, then I give the normal. Okay, sorry. This pediatric patient behavioral changes marked by irritable mood with and withdrawal from social activities rather than social activities together with poor sleep, poor appetite, impaired concentration, psychomotor agitation, restless fidgeting are consistent with MDD. As children must as children move into the adolescence and explore to their autonomy and identify, they may engage in limit testing and desire to spend time with peers rather than with family. However, marked change from the baseline with social withdrawal from peers or declining academic performance as in this case should prompt concern for a primary psychiatric illness and not be dismissed as age appropriate behavior. Pediatric depression may present with symptoms of irritability, annoyance, annoyance and argumentative behavior rather than depressive mood. Identification and appropriate treatment are important to decrease distress and limit impairment in social, emotional, academic development, as well as decrease the risk of suicide. Okay. Okay. Okay, of the medication list, the second generation antipsychotic clozapine is has the greatest risk of causing seizure. Clozapine has the greatest risk of causing seizure. Clozapine is indicated in treatment-resistant psychosis, and as these patients, as this patient's long history of schizoaffective disorder with multiple hospitalization and limited functional independence, living in a group home make it likely that was prescribed clozapine. Clozapine is the most effective antipsychotic for treatment-resistant schizophrenia, schizoaffective disorder, but its use is limited by severe social, sorry, several serious adverse effects, including neutropenia, agranulocytosis, seizures, and myocarditis. Compared with antipsychotics, clozapine carries the greatest risk of seizure. The risk is dose dependent. Compared with clozapine, induced seizure may occur at any level. Tonic-clonic seizure are the most common seizure. Tonic-clonic seizure are the most common seizures are the most common seizure of this type observed. This body dysmorphic type of thing.
Body no, it's not one thing or the other, right?
Mm,
He's a schizophrenia.
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 Medical history. Tearful when discussing how she never want to hurt her mother. Okay, it's very atypical. Okay, obsessive compulsive disorder. Obsessive compulsive disorder is diagnosed by the presence of obsession compulsion or both, with most patients having a combination. Obsessions are characterized by involuntary, intrusive, distressing thoughts, images, and urges, are managed through suppression and neutralization within compulsion. Compulsions are repetitive. Compulsions are repetitive, unyielding, external, hand washing, or mental repetitive counting acts designed to protect against the obsession distress to reduce distress and anxiety in some cases. In some cases, obsession in OCD include unwelcome, violent urges or images, as seen in this patient who has images of stabbing her mother in the back with a knife, followed by her compulsion repeatedly counting from 5 to 1 to neutralize the thought. Okay, it's not other option like A and C. Okay, we know that. Okay, A and C, aripiprazole and haloperidol, are not indicated as monotherapy in OCD. Antipsychotics are used as augmentation in patients with inadequate response to SSRI. B and D, although anxiety and a prominent feature of the OCD, anxiolytic medications such as buspirone and lorazepam do not treat obsession or compulsion. Buspirone, are, buspirone has primary role in the pharmacotherapy generalized anxiety disorder. Okay, yes. Okay, we are We will give a drug which will decrease her depression as well as increase his weight, like mirtazapine. Okay, although there is a considerable symptom overlap with grief, a reaction, and major depression, this patient's worsening depression is concerning. His symptoms meet the criteria of M. Major depressive episodes include depressed mood, loss of interest, insomnia, guilt, low energy, weight loss, thoughts of death. A major depressive episode is diagnosed regardless of existing participants include bereavement. Appropriate first-line treatment for major depressive is antidepressant medication and psychotherapy, although selective serotonin reactive inhibitor are commonly used as a first choice for the treatment of depressive disorder. Mirtazapine would be preferred choice for these patients' poor sleep and appetite. Mirtazapine is the first line antidepressant whose side effects include stimulation of the appetite, weight gain, and somnolence. Got it? Okay, low level of 5-hydroxy indolacetic acid in the CSF, low level of 5-hydroxy indolacetic acid in the CSF is associated with suicidal behavior. 5-hydroxy indolacetic acid is the primary metabolite of the serotonin, which is one of the most important neurotransmitter responsible for modulating mood and behavior. Low level of 5-hydroxyindolacetic acid to thought to represent the dysfunction of the serotonin syndrome. Okay, this is the theme. And the other, like a diffuse 3 hertz spike and wave pattern in the ECG is characteristics of childhood absence seizure. So diffuse 3 hertz spike on EEG is childhood absence seizure, and generalized slowing with periodic sharp wave complex and increased 14-3 protein seen in Creutzfeldt-Jakob disease, and hydrocephalus ex vacuo on CT scan may be seen in neurodegenerative conditions like Alzheimer's, and low hypocretin for narcolepsy. Next. Yes, yes. Okay, bye bye.